near the end of January, someone called my attention to this tweet from Crash Course and SciShow creator Hank Green. I would like to make a video called How to Speak Doctor on things that are a little different between doctor communication and normal human communication. I offered my assistance, but I haven't heard anything, though to be fair, 100 other medical professionals chimed in too. However, it has been 6 weeks, and as far as I can tell, there's been no update, so I thought I'd talk about the topic anyway, with my apologies to Hank if he's still planning on making a video. Why do I think I'm qualified here? For anyone who is new to this channel, I'm a practicing hospitalist, and I teach a 6-semester doctoring course at our med school, which, among other things, covers doctor-patient communication. I have also been a patient myself, and a family member of patients, and I've spent plenty of time on the other side of this conversation. I certainly would not describe myself as uniquely qualified to discuss doctor-patient communication, but I am relatively informed. First, Hank is correct that communication between doctors and patients, or more generally between medical professionals and patients, is inherently different than many other interpersonal interactions we experience in everyday life. For example, there is a power differential between the parties. There's also an information gap. Both the doctor and patient know critical things relevant to the conversation that the other does not. The topics discussed are inherently private, yet details of the conversation are recorded by one side and potentially made available to others by way of the shared electronic medical record. There can be a whole lot of unfamiliar jargon included, and there may be only a very limited amount of time to cover some really important topics and questions. I acknowledge that I am biased by my experience teaching at a single medical school. However, it is my impression that medical schools of today, that is, in 2023, do a relatively good job with teaching effective communication skills. For example, across 4+ years of school, our students receive hundreds of hours focused on communication, many of which utilize what are known as standardized patients. Standardized patients are professional actors and actresses who are trained to portray specific conditions or situations so that our students receive experience and feedback on everything from taking a medical history using an interpreter to delivering bad news to counseling someone on safe sex practices. But you might wonder why. If I'm claiming that medical students are well trained in communication, does that not always seem to be the case when you yourself are seeing a doctor? There are 4 main reasons for this. First, the most straightforward explanation is that some docs trained during a time when communication was not emphasized like it is currently. And that really wasn't all that long ago. I graduated in 2003 and I had virtually no formal training in communication at my med school. Second, without appropriate reinforcement, communication skills degrade over time. There's a myth, not just in medicine but in all professions, that experience alone magically begets expertise. In other words, if a doctor has 20 years of experience in taking medical histories, conveying recommendations, and responding to questions and concerns, that the doctor will have become more skilled in doing so just through 20 years of repetition. However, that is not the case. If anything, I think skills worsen when there is nothing but experience. That is, when there's no feedback or reflective practice. As mentioned earlier, doctors don't always have sufficient time to practice optimal communication. In most outpatient practices, the individual doctor has relatively little control over the lengths on their patient appointments or the size of their patient panel. There's a constant struggle with needing to balance the high needs of a small number of medically complex patients against the relatively lower needs of a far greater number of routine patients. This creates incredible frustration for doctors who feel like they cannot take sufficient time for complicated conversations without sacrificing care elsewhere. There are better versus worse ways for individual doctors to handle that situation, but none of the ways will leave everyone feeling satisfied. And that brings me to the last reason that the communication skills of doctors regress after medical school: burnout, or if you prefer, moral injury. A lack of time, lack of autonomy, needing to run decisions by an insurance company or an administrator, being disrespected by the occasional patient, all this contributes to this burnout, which I think negatively influences the communication that doctors portray. And I don't mean to sound defensive here, but often when the topic of doctor-patient communication comes up somewhere online, it generates a fair amount of, to be honest, doctor bashing, despite individual doctors themselves not usually being the problem. So my first recommendation for patients is to consider that most doctors try their best at communicating with you, and times when they fall short are more often due to external factors than your doctor being an inherently bad communicator. So what are more specific recommendations for patients regarding how to communicate with their doctors? I'm going to divide these recs into those about patients conveying their symptoms, patients discussing recommendations and concerns, a review of some common medical jargon that you may be misunderstanding, and one final point. First is, how should you discuss your symptoms? When the doctor asks an open-ended question, which hopefully they start the interview with, such as, "Can you tell me more about your cough?" that's an invitation for you to share your story. Don't worry that you'll talk too much. If you're sharing more than is necessary or more than there's time for, the doctor will redirect you. While talking about your symptoms, the chronology is extremely important. Whether a symptom has been present for a week or for a month can make a significant difference in its possible explanations. As can whether symptom X preceded symptom Y or vice versa. As much as you can, convey what you've been experiencing in chronological order, starting from when you first noticed your health changing from whatever its normal state is. Conversely, when the doctor asks a closed-ended question, such as, "How long have you been having headaches for?" provide a succinct answer, if possible. Of course, we recognize that not every closed-ended question can be answered in 2 or 3 words, and that's okay. But when, from the side of the physician, when a patient provides a 2-minute response to every simple yes or no question, you and the doctor are going to run out of time. Consider ahead of time what questions the doctor is likely to ask you about your symptoms. There's a helpful mnemonic for this, OPQRST. The O stands for onset, when did the symptom first start? Provocation and palliation, does something specific seem to trigger or relieve the symptom? Quality, for example, experiencing pain, is it more of a dull ache, an intermittent cramp, or an abrupt stabbing sensation? Region and radiation, where does the symptom feel like it originates? And radiation refers to where the symptom feels like it travels to. S is for severity, and T for timing. For example, if it's an episodic symptom, how long do the episodes last, and how often do the episodes occur? Why do you need to know this acronym? Why can't you just answer the questions from memory as the doctor asks them? Sometimes patients need to think about it. And, in the context of an already rushed appointment, you may feel rushed to respond with, "I don't know," if you haven't considered these specific questions ahead of time. Conveying the severity of pain is a particularly challenging moment within the doctor-patient interaction and requires a few extra minutes to talk about it. Just about everyone is familiar with the 1 to 10 pain scale. Pain scales can be helpful as a semi-quantified way of tracking pain over time, but they don't capture the full experience of patients. If the doctor does not prompt you for this, mention the functional limitations the pain is causing. For example, a patient might say, "On a good day when my back pain is a 3, I can work a full 8-hour day as long as most of it is not on my feet, but on a bad day when my pain is a 7 or 8, I can't concentrate for more than 15 minutes at a time." I actually recommend framing the severity of every symptom, not just pain, but every symptom around the impact it has on your quality of life. Instead of saying, "My trouble breathing is really bad," one could say, "My breathing makes it impossible to go grocery shopping." Also, as I was just talking about the 1 to 10 pain scale, don't give a number higher than 10. Too many healthcare professionals will interpret that to mean the patient is unreliable. That's not a fair or appropriate interpretation, but I am telling you that is what happens. If you really want to convey that you are experiencing 20 out of 10 pain, the better and less biasing way to do it is to say something like, "This is the worst pain I have ever felt in my life." Something else to not say, which we hear relatively frequently, "I have a high pain tolerance." Now, most patients when saying that mean to convey something like, I am used to chronic pain already, and I would only come into the ER if it was really, really bad, much worse than the pain that brings in most people. However, and that would be fine. That's how it was interpreted. That would be fine. However, what most medical professionals hear when one says, I have a high pain tolerance, is, I want opiates. Why is that? After years of practicing medicine, it is my consistent experience that many, not all, but many patients who use that phrase will in fact ask for a specific narcotic within the next 5 minutes. It does not mean that the pain isn't real. It doesn't mean that a narcotic would be inappropriate, but it does give the appearance of drug-seeking behavior, which is honestly a very real problem in medicine, just one manifestation of the pharmaceutical-driven opioid crisis. So instead of saying, I have a high pain tolerance, when trying to convey the severity of pain, I recommend saying something more along the lines of, I've learned to function at a level of chronic pain that would have incapacitated me if it had developed overnight, but what I'm experiencing now is the worst pain I've felt in many years. This is not normal for me. The next broad topic is discussing treatment recommendations and your concerns with your physician. If you have a question or concern ahead of time, write them down. Even if you feel certain you'll remember, it's actually really easy to forget during a medical appointment. And if you do have a specific concern, either one that you had from before the visit or something that crosses your mind in the moment during the visit, be upfront about it. Whether the concern is a specific disease you think you might have, or something like you want to avoid a new medication because you don't think you can afford it, that's important information for your doctor to know and can change the entire flow of the conversation. Always ask for the risk and benefits of any recommended treatment. That includes asking if there are non-pharmacologic treatment options. That is, things other than medications that could help. And ask what are the possible outcomes if you decline treatment. And some doctors, may scoff at that question about declining treatment. And, if they do, at the very least, that's a clear indicator that you need a new doctor. I discussed this more in my video on medical gaslighting, but if you feel your doctor is dismissing you or not considering your symptoms or concerns as seriously as you think they should, it is absolutely appropriate to call attention to it. But for the most productive response, I recommend doing so in a respectful way. Most doctors will react positively to phrasing like, Dr. Strong, I'm worried that you don't seem as concerned about my stomach pain as I am. I don't know if you understand how much this is impacting my life or how concerned or scared I am about it. It is true that some doctors may still blow this off, but when most hear a patient say something like this, it's a sign to them that their communication is falling short, and they will slow down the pace of the conversation to be sure both of you are understanding one another. The next topic is medical jargon. Even great doctors who are skilled at communication will occasionally use medical jargon. Let me talk about some of the more common terms with which patients should be familiar and which I think a lot of patients actually misunderstand. A differential diagnosis, or just differential for short, is the list of diseases that a clinician is considering as possible explanations for a patient's symptoms or test abnormalities. Related terms are to rule out and rule in a diagnosis. To rule out a diagnosis does not mean that the diagnosis is literally impossible, but rather that it is unlikely enough that the medical team does not recommend continuing to test for it at the present time. Likewise, to rule in a diagnosis does not mean that the diagnosis is definitely without question the cause of a patient's presentation, but rather that the diagnosis is likely enough that continuing to test for any alternative explanation is not warranted. Last, occasionally a doctor may prescribe treatment for a disease before that disease has been ruled in. This is what is known as empiric treatment. For example, a doctor might tell a patient, I'm not sure if you have pneumonia, but the balance of harm and benefit from antibiotics in your case, even with that uncertainty present, still favors you starting them while we gather more data. Sometimes, in fact, it will be the response or lack of response to empiric treatment that helps to rule in or rule out a suspected diagnosis. I have one final recommendation to patients when talking to their doctor. Don't lie. Now, there are a few reasons why patients lie to their doctor. Sometimes patients, for example, may exaggerate symptoms deliberately because they're afraid if they don't, they won't be taken seriously. I've heard that most frequently from women, and in particular, women of color. And I understand that concern. There is a very real bias there, and this is one of the topics that contemporary medical school curricula address. But I do think discussing your symptoms in terms of the functional limitations they impose on you lessens such biases and will help to make exaggerating symptoms feel unnecessary. Exaggerating symptoms is dangerous because it can lead to unnecessary, sometimes expensive tests, which can have their own risks associated with them. Exaggerating symptoms can also land you in the hospital unnecessarily. More testing and hospitalization are usually not good things. Another reason that patients lie to their doctor is because they're embarrassed. For example, if the patient didn't take their meds, or they've been abusing drugs or alcohol, or have been eating poorly. But trust me, no matter how embarrassing what you've done may seem, your doctor has probably heard worse and would much rather you disclose everything so you can receive an accurate diagnosis and the care that you need and the care you deserve. Every doctor, even those with suboptimal communication skills, wants their patients to get better, and they need every piece of information to help make that happen. That's it for my advice to patients on speaking with their doctors. I hope you found it helpful. For those patients who've had particularly negative interactions with their doctor before, you may find a related video I made on the phenomenon of medical gaslighting helpful as well.